Thank you. Distinguished panel, ladies and gentlemen, it's an honor to speak here today. So I'll say some controversial things, but I want to say at the beginning that assessment of valve function is obviously the mainstay is echo, but we like CT. We like CT because we have 90-year-old patients. They have an investigation in 0.3 seconds. We also know that we can assess even bioprosthetic function very well. And then we turn to valve function. We can see very, very clear images with superior spatial resolution. And we can delineate very clearly calcification. You see here on the top left image, you see partial fusion causing aortic stenosis. You see limited calcium that can help us decide which valve we choose. We may prefer a self-expanding valve in such a case. In this case, we see some form of what we would describe as a functional bicuspid. We see 3 commissures. We see calcification, which may be the cause of the fusion of these 2 leaflets. And in these 2 cases, we very clearly delineate critical AS. We see a pinhole orifice with a non-Raffi bicuspid. Here we see a slit-like orifice from a Raffi-type bicuspid. So we're very, very much turned to the CT where we have these gray zone cases with intermediate gradients, because we get a very tactile feel of a very, very visual assessment, very clearly assessing the degree of stenosis, at least anatomic stenosis. I highlight this case with extensive asymmetric calcification and a Raffi-type bicuspid because we know exactly the anatomy and the risks to this patient. So we can see the calcified RAF, we can see the commissural calcium that can sometimes be a substrate for paravalvular leak. We can see also that there's asymmetric calcium. This leaflet doesn't have calcification, so that can sometimes result in a canted valve, and we can anticipate these potential problems that can arise when we assess the valve function. Now, this is a historic case because we don't get paravalvular leak anymore, obviously, but this is what looks like severe paravalvular leak in a case with severe LVOT calcium. But I can tell you that this case, in fact, it looks severe, paravalvular leak with a big hole, but in fact was 5 years out with good hemodynamics. So there are clearly discrepancies, and the CT, in fact, guided us in that case because we didn't want to post-dilate and rupture an annulus that in a physician that we had been caring for some time. From the previous speaker, we heard very elegantly that MRI has value in assessing forward and backward flow, and also echo is very valuable, but we do use CT to help guide us if we have paravalvular leak and we want to close it with a plug, because it guides us where the likely anatomic location is. So here we saw a dense nodule of calcification. This is even a non-contrast CT. And here the jet appears to be anterior, but in fact we knew from the CT that the likely substrate was malapposition laterally, and that's where we went for. One thing to bear in mind with these paravalvular leak jets is that they're often serpingous, so they can enter at one point and exit at another point, and that can be very challenging. So we were guided by the CT in this case. Just very simply under the left mainstem we aimed and put a plug, and here you see flow wave reversal. There's still a little bit of a jet, but flow wave reversal disappeared and the patient did well. So one thing to note from the 4D CT experience, we still look at it as probably the most reliable assessment of calcification. The CT report said very plainly here severe valvular calcification, but you can see from the CT there's hardly any calcium. So in fact, that guided us more to a self-expanding valve in this case, with good result. And again, this case, again, the report said severe valvular calcification, and you see almost no calcification on the 4D CT, and very clear images. So one thing from Miguel's talk, he did show a case which had low gradients, and this case actually did have low gradients as well, but we went ahead and did the TAVI based on the anatomic appearance, both on echo and on CT, because our sentiment is that catheters may be able to open pliable leaflets, so we may push aside a stenotic valve that may still have anatomic consequences to the patient. So we went ahead and did this case, even though the gradients were low, not quite as low as Miguel's case though. The other thing to bear in mind, CT can assess the whole body anatomy as well as cardiac structure and function. I'll finish with this new concept of using CT in assessing mitral valve function. Obviously, the mainstay is TE. We get beautiful images from 3D TE that are basically indispensable with this procedure. We know that we're primarily targeting central MR, but we can assess and treat many locations of MR. We can treat degenerative MR, functional MR. We just need to have sufficient leaflet tissue and be able to grasp that for mechanical coaptation. So really this original schema for exclusions has declined, but with CT we can also determine the anatomy. So if we have a very good transthoracic echo and a frail patient, we don't want to do TE prior to the procedure. These are the 3D TE images we actually had intra-procedure, but on 4D CT you get very, very detailed anatomy, and basically we can determine also that this was a P1 flail. We can determine very precisely the extent of mitral annular calcification. We may also have considered this patient for the new TMVR procedures, and this CT also assesses patients comprehensively for those procedures. So one thing we can do with the 4D CT is we can basically have a freeform X-plane. So this is cutting laterally, cutting medially A3, P3, and you see here there's good coaptation, so the problem isn't there. You can see A2, P2, there's good coaptation, the problem isn't there. It's where you see it in the 3D. You see the flail posteriorly in P1, and that's the substrate here. This is easily clippable. You can determine that with a combination of the 2D TTE and the 4D CT. We can also get a very good bicom view that mimics the 3D echo views very well, and we can also look beneath the valve and have a transgastric view equivalent. So first set of conclusions, there are clear benefits from the CT assessment of native valve function. It's non-invasive, it's a rapid, comprehensive assessment of whole body anatomy and cardiac function. We have superior appreciation of calcium. We have unprecedented spatial resolution and now temporal resolution that is comparable to 3D echo. There are clear limitations. We're unable to assess regurgitation reliably. We require contrast. We require radiation. It's already prime time, so we're using it in a busy TAVI practice. We're using it to assess stenosis severity. We're using it for further understanding the patterns of calcification in the setting of that stenosis. We're looking at valve morphology, and we also have the benefits, the gold standard for sizing, at least in our opinion. We're using it increasingly with MitraClip to understand the underlying etiology, and at the same time we're assessing such patients for alternative novel therapies. Thank you very much.